Smigielski. He has got wonderful work on anatomy of the knee, including posterolateral corner and medial corner of the knee. Last time we had a wonderful discussion on PCL, ACL, and posteromedial corner, and we left with the posterolateral corner. So I think we are going to take over the remaining part of the discussion from today. So I'm going to request Dr. Abhay Narvekar and Dr. Ranajit Panigrahi to moderate the session, and we have a wonderful panelist, Dr. Vivek Pandey. Dr. Nishith Shah is joining us in some time. Bhupesh is joining us. Dr. Bhushan Sabnis. Bhushan, hi. Dr. I.D. Singh, Rajiv, Raman, and Rakesh Choudhary. So all these panelists are going to discuss in great detail about the anatomy, and we are live on YouTube now. Dr. Robert, welcome.
Hello. Sorry for delays.
Yeah, no problem, Robert. I'll just request moderator Dr. Abhay Narvekar and Dr. Ranajit Panigrahi to moderate the session. Ranjit, Dr. Abhay.
Yeah, Abhay sir.
Yeah, welcome, Robert. We are looking forward to your presentation. We had a lovely time the other day, so welcome back. And all of us had coffee, and we are ready for your presentation. So let's go ahead. Let's mute everybody, and I think you can share your screen.
We start with the lateral anatomy. Yeah.
Yes, Robert. Yes.
Okay. Can you see my screen now?
Yeah, we can see. Just make the slideshow, and I'll mute everyone. Just a minute.
Can you see the lateral anatomy, the first slide?
Yes, we can see it. I'll just mute everyone so that you can speak well.
All right.
Okay. Thank you.
I'll just talk a little bit more about the lateral anatomy from the anterolateral to the posterolateral. And this is the superficial anatomy. You can see here some fibers which are running from the IT band and just curving here and going across the patella to the medial side. Then you can see here, this is the Gerdes tubercle, and this is the explanation. Then we have here the head of the fibula, we have the Gerdes tubercle, we have the 3 is the long head of the biceps tendons, then 4 are the fibers from the short head of the biceps, 5 is the IT band superficial part, and the 6 is the superficial part running to the patella, and then finally we have the 7 is the infrapatellar branch of the saphenous. You can see here this with the arrow. When we had the same in the flexion, you can see same structures but bit different anatomy. You can easily recognize this gap here. Through this gap, we can find small branches of the saphenous nerve. Sorry, of the lateral cutaneous nerve. And what you can see here, sometimes, or really could be quite often, one can just make the incision for the arthroscopy here, and this area could be really painful. If you can see here, the small branch, the nerve branch, it could be a really painful area after the anterolateral portal for the arthroscopy. Going forwards, 1 is the fibula head, 2 is the Gerdes tubercle. This is very important because between 1 and 2, we expect sometimes here in this distance that it's supposed to be here the LL, or it's supposed to be here the second fracture on the level of the tibia plateau. We have 3 biceps femoris, 4 fibers from the short head of the biceps femoris. Then we have 5 the IT band superficial part, and 6 the fibers running to the across the patellar tendon. 7 is the branch, and the 8 you can see here. This is the LCL. What happened when we just remove the superficial layer? You can see here. Sorry for that. You can see here we have this one, and then we have this. Look what happened when I just make the external rotation. So internal rotation of the tibia. You can see here the most tight structure on this level is the deep part or the posterior part of the IT band. I will just show it in one minute how it looks like. This is discussion about the lateral knee anatomy. Then we have the next step. You can see I just remove the IT band, and again, you can see the hammock, the structure which is here. We call it the capsuloocellus layer, or some guys say that this is the described by Lobenhofer. These are some fibers running from the IT band, and we call it the capsuloocellus layer. You can see here, this is the hammock running fibers here. And this is very important structure, because if you look at that, then we have the Kaplan fibers. Some people say this is one kind of the Kaplan fiber, but I'm retrograde Kaplan fiber. Then we have two, is the deep IT band, deep IT band, or capsuloocellus layer, Gerdes tubercle. And this is very important. These are very important landmarks. Patella tendon, of course, and the lateral head of the quadriceps femoris. Then we go the step next. I split it from the back. I just split it this from the posterior. It looks like I'm gonna split the tendon, and then the IT band. You can see what happened deep here. This is the septum, short head of the biceps femoris. Here, and these are the fibers from the short head of the biceps femoris. Can you see here? They're running to the anterior lateral part of the tibia plateau. When I pull it, it's also some movement of the tibia, but it's not so strong that these fibers are not so important. Then we go from the back. This is from the back. I just, as I showed you here, I just splitted that, and then we have the septum is here, and these are the structures which are from the posterior part, from the back. And what we have here, you can see, sorry for this, these are the vessels. Then we have deep IT band, it's two here, this is one, this is the bundles, the vascular nervous bundle. Two is deep IT band. This is this capsuloocellus layer. You can see here. This is the structure here, or deep IT band. Three is the landrow ligament, or the ligamentous strap, and four, these are the couple of fibers. Then look at this movie, please. You can see how it looks like. What happened when I try to make the rotation, these fibers are tight. And then we go to the Kaplan fibers. The Kaplan fibers, they have a very specific role. They just anchor the IT band to the femur, and they just make some arches. Under the arches, the vessels and the nerves, they go through from the posterior to the anterior part. The Kaplan fibers are these structures. And what happened, very important, I try to make it short. What happened when I remove the IT band, I leave the deep IT band, I left it. Look at the movie. Can you see this is the deep IT band, or the very posterior part of the IT band? And this is this capsuloocellus layer. When I make the rotation, the superficial part is not so tight. Deep IT band, you will see that again. This is the superficial part. I cut the superficial IT band, doesn't change much, but you can see the very thin structure, which is deeper, which is gonna be tight when I make the rotation. This is this one, okay. No. Okay, and now what happened when we have this deep IT band? And please have a look what happened when I cut it. This is the anterior lateral rotational instability. When we cut the deep IT band, very thin structure or capsulo-osseous layer. Okay, but someone can ask, okay, what then when we have these structures? What is the structures? This is the very old movie from 2008 that you can see here. This is the ALL. Definitely, we cannot discuss it. ALL is the same structure like described, but has also some role in the limitation of the rotation. That one. And please look again at this movement. This is the lateral side. When we go deeper, then we go directly to the lateral meniscus and to the LCL and the popliteal tendon. But I would like to show you what happened with the lateral meniscus when we flex the knee. When we flex the knee deeply, then the meniscus moves on the lateral side up to 2 centimeters from the anterior to the posterior. This is the series of different pictures. Please have a look at the lateral meniscus, LCL, and the popliteal tendon, and you can see how change the position, the orientation, the structures, while flexion and extension. The lateral meniscus, which is here in the 90-degree flexion, moves approximately 1 centimeter backwards, which is not the small distance, it's a quite big distance. If we take the whole distance of the lateral tibia plateau, in average is 4 centimeters, it's like 25% of the whole tibia plateau, lateral tibia plateau. From full extension to around 90-degree flexion. And of course, what is very important, the attachment of the popliteal tendon moves anteriorly, and then we can see the attachment of the popliteal tendon in front and anterior to the attachment of the lateral ligament, lateral collateral ligament. From the posterolateral side, you can see here, this is the popliteal tendon. Then we have the lateral meniscus and the lateral collateral ligament, biceps, the long head tendon, biceps major long head tendon. But what's very important, the connection between the meniscus and the popliteal tendon. These are the menisco-popliteal fascicles, posterior superior and anterior inferior. I will show you in the short time the next things. Also on the lateral side, which is very important, lateral collateral ligament, popliteus complex, together with the popliteal tendon, the popliteal fibular ligament, and the lateral meniscus mechanism. Let's have a look again on the lateral side. Then we have the lateral collateral ligament, popliteal tendon, and meniscus. Very important is just to observe the movement of the lateral meniscus on the lateral tibia plateau. Why is so important? Because the lateral meniscus is a very special structure in the knee. The lateral meniscus is a very mobile structure, is the most mobile structure in the knee. Comparing to the medial meniscus is double or even 2.5 times more movable than the medial meniscus. Let's go to the lateral meniscus. We did this study. These are the study. We asked 36 volunteers. We did in 3 Tesla MRI, 3 different MRIs in different flexion angles, full extension, 30-40 degree flexion, and the full flexion. Why only 3? Because the diameter of the coil was not enough big just to show everything. We could make the examination, the full extension, just a slight flexion until 30-40 degree, and then we removed the patient, flexed completely the knee, and just did again the MRI. What we analyze the movement of the menisci and other structures. I would like to be focused on the lateral meniscus. Then you have the lateral meniscus here, the lateral tibia plateau, lateral femoral condyle, and just please observe how change the position the lateral meniscus on the MRI from the full extension to the full flexion. It's going again. if you can see that, you will see that this is, you know, really big movement from the full extension to the full flexion. And if you look on the tibia plateau from the top, you can see full extension and the full flexion, and you can see how change the position of the lateral meniscus and how change the position of the medial meniscus. It's almost the medial meniscus almost the same position, while the lateral meniscus moves a little bit far posterior. And this is, you can see how change the position of the meniscus. When we compare it, it's approximately that's just a little bit slow. Hello, can you hear me?
Yeah, we can hear you. I think your computer is not moving. Slide is not moving.
Well, it's freezing. I can see the pictures are freeze. I try to.
You should reconnect. The last time we had the same situation, you had to reconnect.
Maybe I have to reconnect it. That's maybe a good idea.
Unshare and share it. Unshare and share it again.
Yeah, unshare it. I'll just unshare it. Stop participant sharing, and you can reconnect it.
Okay.
Sandeep.
So sorry, I had to reconnect it.
Yeah, I think there is some problem.
Yeah, just try now. I think it should work. Dr. Robert.
Robert, can you hear me? Sandeep, I think there is some problem.
Yeah.
I think he's reconnecting like we did the last time, because last time we had the similar issue around the same time of the presentation. So please give him a minute to
no problem.
switch to the other line.
I think the video is a problem. And these are very heavy videos because of high.
It would be good if the host of the meeting would make Robert's presentation disappear, because he might not be able to reconnect.
Yeah, I'm trying my best, but I am unable to do it. Sandeep,
just make me for host and do it.
Okay. Sandeep, you are host now.
If anyone shares his screen, I think that will be automatically go, na? Yeah, that will automatically go.
I think it will work now.
Can you hear me now?
Yeah, we can hear you, Robert.
Okay, correct. And we can go.
You need to share your screen.
Yeah, I try to set up again. Where is this? can find you.
Problem now?
You can press on your presentation, open in desktop, then press on Zoom icon.
Yes, that's right. But I just have now the presentations here, and then I'm looking for the Zoom. I cannot find the Zoom. I don't know where is that.
You will see.
All right.
Zoom
Okay.
on.
Let's find it. Right. It's okay. It's fine. Okay. Can you hear now?
Yeah, we can hear. Sandeep,
right.
can you mute everyone?
Hello, can you hear me?
Yes, please go ahead, Raman.
All right. This is the last picture probably you saw the lateral meniscus and the movement of the lateral meniscus on the lateral side. And then we can see how changed the position of the lateral meniscus, and that was in average 2 centimeters on the lateral anterior plateau. It means the lateral meniscus is, for the lateral meniscus, is very important to be mobile as much as possible. What is the popliteal hiatus? This is also the lateral anatomy. The popliteal hiatus has a very important structure, the popliteal tendon, but the popliteal hiatus consists of the meniscus and the popliteal tendon, and the meniscus is very well attached to the popliteal tendon, which is very important. This is a short movie. You can see here. You can see here, this is the anterior superior, the inferior and the posterior superior fascicles. And this structure, this is the meniscofibular ligament. I will show you. Then we have also the ligaments, the popliteal meniscal ligaments or the popliteal meniscal fascicles. And this is the very important structures because they increase the stability of the meniscus, and this is extremely important if we have the unstable lateral meniscus. If you look at these pictures, you can see here, as I said, the anterior, this is the anterior part, this is the posterior part. I cut it here, the posterior part, just to show how connected is the meniscus to the popliteal tendon. There's quite strong connection, it's quite strong structure, which fix the tendon to the meniscus or meniscus to the tendon. While flexion and extension, the meniscus, because of this structure, can move properly. From the back, you can see again this structure here, but this is also very important. This is the popliteal fibular ligament. We have the head of the fibula, and this is the popliteal fibular ligament, which is very important in the posterolateral corner reconstruction. And now you can see the short video. You will see here, I will just cut the structures, the popliteal meniscal ligaments. You can see now when I cut it, what we get. We have here is the popliteal tendon, and here are two structures. Deeper is the meniscofibular ligament. More superficial is the meniscopopliteal inferior meniscopopliteal fascicles or ligaments. What is the role of these fibers? The stabilization of the meniscus, and first of all, the stabilization to the anterior, to the front. Means these ligaments, they just stop the movement, the movement of the meniscus to the front. A very important, very not so much well known meniscofibular ligament. I will show you this. I would like to show you that this is very important structure, very rare described. I found only a couple of papers in the literature, in the different sources, but you can see here, this is the meniscofibular. Meniscofibular ligament attach the meniscus, connect the meniscus and the tip of the fibula. And this is the very important stabilizer. You will see that I will show you the cutting study. This is again, meniscofibular ligament, which is deep. is deeper to the popliteal tendon and is deeper to the meniscopopliteal fibers. And now you can see the structure. This is the structure. It's really strong structure. It's really hold the meniscus in the proper position. And now you can see how change this situation. You see, just this meniscofibular ligament is very important for the anterior lateral meniscus stability. So now please look at the movie. I cut the meniscofibular ligament, and then the anterior movement of the lateral meniscus increased significantly. And there is another thing. I cut the meniscotibial ligaments, coronal ligaments, and then the meniscus moves anteriorly. This is another example. This is the meniscotibial ligament. I will show you that in the separate presentation. Meniscotibial ligament, we have stopped the movement of the meniscus to the front, but not so significantly, but very important for the lateral side is the posterior root of the lateral meniscus. And this posterior root of the lateral meniscus, if you want, I can show you on the separate movie what happened when we cut the posterior root of the lateral meniscus. Thank you. And sorry for the technical problems.
Thank you, Robert. I think that was a wonderful presentation as far as PLC is concerned. Is there any question from anyone?
Yeah, Roshan.
Yes.
You know, this is quite to understand that how
that voice.
Yeah, the thing is that, you know, arthroscopy.
Hello, Dr. Abhay.
Can you hear me?
Yeah.
Yeah, can you hear me?
Yes.
Yeah.
Go ahead, Dr. Narvekar, go ahead. We couldn't understand your question.
The question, I have not finished it. Whenever we do an arthroscopy, we actually do not appreciate this.
No, we can't hear you.
Lateral meniscal movement of almost. I'll let somebody else ask. There's some problem here.
I think, yeah. Vivek,
now you are audible.
Robert.
Abhay sir, now you are audible. You can ask.
Vivek, yes.
Yeah, Robert, can you hear me?
Yeah.
Yep. Thanks for showing we all knew a bit about all these popliteals, popliteofibular, and all those things. But thanks for giving us the detail of these meniscofibular fibers, and then how these meniscotibial and how they help in micro-stabilizing the entire segment. But the question is, when the PLC is torn, okay, how do you reconstruct these little small fibers which are all behind, inside? I mean, they're nice to see on a cadaveric dissection, and we know that how intricate they are. But the question is, what is the way to, to reconstruct them? Acute, yes, you can go and repair those things, because some fibers you'll find. But in case of chronic, how do you reconstruct? Do we have anything?
In the chronic instability, I just try to put the suture. There's, the passing sutures. If I want to reconstruct, or let's say reconstruct the meniscofibular ligament, I put the suture from the lateral side, from the anterolateral side, and the superior anterolateral approach, going down. And then you can just use the shoulder instruments, like the banana, and you can go through the meniscus deeper to the tip of the fibula and put the suture. Of course, this is not real reconstruction, but then after that, I did it maybe 3 times in my life, but it's fixed the meniscus very, very nice, and there's no subluxation of the lateral meniscus. The role of the meniscofibular ligament is, just to limiting the anterior movement of the lateral meniscus, which is sometimes a very big problem in the subluxation, some locking knee, and so on.
Robert, you spoke about the Kaplan fibers of deep the IT band. And that Kaplan fibers is the one which, according to you, gives an additional rotational stability to the knee joint, which we spoke about the ALL. You know, there are certain groups we speak that the stability primarily comes from ALL, whereas certain people say that it is not the ALL, it is the deep Kaplan fibers of deep IT band. So what exactly gives the rotational stability?
Yes, I can tell you that's my opinion is that the both structures, the ALL and the deep Kaplan fibers, they are very important for the rotational instability. But what is important, the ALL is the most important to rotational instability closer to the full extension, between, let's say, 30 degree to the full extension. The Kaplan fibers, the deep IT band is between 30 degree, 45 or 60 degree flexion. We should take under consideration both structures, the deep IT band and the ALL, because they play a very important role, but in different flexion angles, different range of flexion. And that's why in my daily practice, in my office, during the knee examination, I try to differentiate which part of the, let's say, the extra-articular stabilizers is damaged, deep IT band or LL. And according to that, I go for the different kind of reconstructions.
Okay. Second thing is when you see the posterolateral corner and lateral corner, there is a bioplasticity in those tissues as compared to the medial side. Medial side, MCL and the posteromedial complex is very, very tight, whereas the lateral side is usually lax, the normal laxity. So is there any mechanism by which we can study this normal laxity so as to avoid the abnormal laxity which can coexist in ACL tear or PCL tear?
Honestly, I don't know the answer on your question, but that's true that the lateral side is much mobile than the medial side and much longer than the medial side. But what we can do, I try to avoid to make the tenodesis. Like if you know the Engebretsen and Laprat posterolateral corner reconstruction, this is the base of the tenodesis. You make the popliteal tendon tenodesis, then you put the one strand which is the popliteal fibular tenodesis, and so on and so on. And of course, it looks very good, but I try to suture my structures, and it works as well. And I have also a very good relationship to Bertrand Sonnet-Cotet from France, and he has his own technique. He makes some half tenodesis of the popliteus tendon to the posterior tibia arthroscopically. It means every knee, especially the rotational instability, have to be analyzed separately and have to be analyzed according to the structures that could be or they are damaged or ruptured. I don't know the answer, the good answer on the question probably.
Dr. Nishith, you have a question?
Robert, you have shown that the lateral meniscus normally also moves so much. So when we do meniscus repair, lateral meniscus repair, especially the anterior half, we should not be very tight, because otherwise we will lose the mobility of the meniscus.
Yes, that's what I want to say. That's right. But I have the second presentation about the meniscus anatomy and anatomy guided surgery, proposal of the surgery. And I would say that I just divide the lateral meniscus into different zones. And depends in which zone is the injury, it should be differently managed. That's my opinion. I will just show you that in a couple of minutes.
Yes, Dr. Rajiv, can Bhushan, Rajiv, yes.
Yeah. Because nowadays, you know, people they put the sutures above the meniscus, below the meniscus. So many sutures they put and makes it. I would be very happy to see the next presentation. Thank you.
Yeah, that's soon. I will just start soon.
Yeah, Bhushan.
Actually,
we can't hear you.
Can I ask?
Yeah, Narvekar, sir.
Robert, actually when we do the arthroscopy, we don't really see the anterior portion of the meniscus moving almost 2 centimeters posteriorly on flexion. We also see that there are a lot of fibers which over here in your dissection have been removed, but which are there from the periphery of the anterior horn of the, or not anterior horn, but the anterior 1/3 of the meniscus, going towards the fat pad and to the flimsy anterior capsule. And is this that these fibers prevent that degree of posterior movement that you have shown of the meniscus? Because it almost showed as if the intermeniscus ligament goes almost 2 centimeters posterior.
I think just let me discuss it after I talk about the meniscus anatomy. Then we can just we can discuss that.
Yeah.
Rajiv.
I think,
yes.
The infrapatellar lateral branch, you told that it's very close to portal, and sometimes we have a portal tenderness. Patient have portal tenderness there. So, how far it is, or what is the real location from the lateral border of the patellar tendon, infrapatellar branch?
I do the anterolateral portal just very close to the patellar tendon, because I use it also for ACL reconstruction. I would like to have just as much in front as possible, anteriorly, and then in that I just try to avoid to cut the small nerve branch, because if in the past I did it just a little bit far lateral, just more laterally, and sometimes what's happening that I just cut the small artery or small nerve branches, which is going exactly what I showed you. Let me find this picture. I will just show you again that, because very interesting question and very interesting structure. Not so many people are mentioning about it, but this is quite often.
We never thought about that. The infrapatellar and lateral portal, we were more worried about the after graft harvesting about the medial neuroma.
I will show this. Yeah, but this is, I don't know if you can see my.
Yeah, we can see your screen, Robert.
Can see.
Nerve branches here.
Yeah.
And this is exactly very close to the place where we put the anterolateral portal. And I try now to put it as much as close to the patellar tendon. When I just shift it more to the lateral side, quite often I just cut some structure here. I have the bleeding. I have the down. After that, I have the pain on the anterolateral portal. But when I started just to put my portal closer to the patellar tendon, I have no problem with the lateral side with the bleeding. Probably you observed also that sometimes there is pretty big bleeding from the anterolateral.
Yes.
This is because here we have the nerve branch, and the parallel to the nerve there is a small artery which is going together with the nerve. It's like the perforator, and this is exactly this this area.
Okay.
Yeah, Robert. Hello.
Yeah.
Can you tell something about the arcuate ligament? Do you consider it a part of posterolateral corner? Because many radiologists, they show it very close to infralateral genicular artery. Some say it's a thickening of the capsule. Some say it's a separate ligament. So can you tell us something about this arcuate ligament?
Arcuate ligament.
Yes.
Let me find a picture maybe. We'll just. Because this is not the lateral, this is more posterior part. That's not easy, because that's this is the, for example, this is the one of the picture. But on all my pictures, the posterior capsule is removed. That's why it's not easy. But the arcuate ligament is important for the rotational stability as well, in my opinion. I don't know if you can see my screen.
You can share it. Share your screen.
Yeah, what is it?
Zoom.
This only.
Zoom icon and share.
Yeah, no.
Yeah.
These are probably the only pictures I have from the posterior, but on all my pictures, the posterior capsule is removed. But the arcuate ligament is responsible for the, more or less the rotational stability. But very important structure. It's not arcuate, of course, but this is this one, which is also very quite often discussed. What is the role? This is the Popliteal fibula ligament, fibulo-popliteal ligament. Can you see these fibers here?
Yes, yes.
And this is important for the rotational instability. When we do the Laprade technique, we put the tunnel in the fibula head, then we go to the fibula head here in this point, and then we put the tunnel through the tibia, and then from here to there is another graft. It's 1, 2, and this ligament is the ligament which make the unlocking the knee more dynamic.
Okay.
Because it fixes the fibula. Sorry, I cannot show you the arcuate ligament.
No problem.
Okay.
How much
Yes, Dr. Nishith. Hello, Nishith, we can't hear you clearly.
Sorry. How much shall I ask? Okay.
Yes, yes.
Bhushan, you go ahead. Sorry.
No. Ask your question. Nishith, you can ask your question. Hello.
Okay. Robert, how much, Robert, can you listen to me?
Yeah, we can hear you. No problem.
Hello.
Yes, Nishith,
okay.
Go ahead. We can hear you.
How much PCL is contributing to the lateral
I can hear you. I can hear you.
So he is asking how much PCL is involved in lateral instability, rotatory instability, posterolateral rotatory instability.
What is the contribution of PCL in posterolateral stability?
Posterolateral stability.
Yeah.
I show you now. The posterolateral stability. There is, if you look, this is the good picture probably. The PCL is the rotation center. We have here. If you look at this picture, there are pictures they should present. Can you see that?
Yeah, we can see it.
Yeah, the PCL is the center of rotation. And of course, the posterolateral corner is here, and the PCL has not so big contribution. If you just fix the knee in the proper rotation, the PCL play the important role, but not as important for the rotational instability. That's the center of rotation.
Okay. Any other question?
Yeah. Can I ask question?
Robert,
Yeah.
Yeah.
Yeah, Bhushan.
Yeah, Bhushan.
Unmute. Bhushan, you have to.
Bhushan, we can't hear you. I think your microphone is not working.
Yeah, any role for fibular ligament in the rotational instability of the posterolateral corner?
Fibular ligament. Robert, any role of fibular ligament?
Too many questions at the same time. What is
fibular ligament. Fibular ligament.
Yes, the fibular ligament is also a very small one. I didn't show it on my pictures, but this is the one of the components which supposed to be responsible for the rotational stability. But there is many of them. We have the fibular, we have the popliteal fibula, we have the menisco-popliteal ligaments. There is many of them, but the fibular ligament, I don't know any biomechanical study about the importance of the ligament.
Roshan, can I ask question?
Yes. Please go ahead.
Yeah, Robert. This is Vivek already asked this question. Actually, I have this question in my mind for the last 3 years. The menisco-fibular ligament, menisco-popliteal ligament, the smaller ligament which contributes in the stability of the lateral meniscus. So, in chronic cases, can you replicate with the reconstruction with the fascia lata or some other thing? What is your opinion?
The idea is good, but technically it could be very, very difficult because this ligament, it's going, if you look at this ligament, I will show you the anatomy of the ligament. It's not so easy to get it. Arthroscopically, maybe it could be possible to do that, but let me find a picture. This one. Okay. Okay. Now can you see that?
Yeah, yeah.
This is deep to the other structures. Superficial to the meniscofibular ligament. We have the popliteal tendon. We have the capsule. We have the popliteal meniscal fascicles. It's really deep. It's maybe the movie. I just fear it's better to show it. Find it. This one. Okay. Can you see this?
Yeah.
Yes, yes.
Right. Look at it. This is the popliteal tendon, menisco-popliteal fibers here.
Yeah, yeah.
And what is then? Deep here, this structure, this one, this is the meniscofibular ligament. If you want to go from the outside, you have to go, next to the LCL, next to popliteal tendon. It's really very deep one. If I do the dissection, it's really deep. Arthroscopically, it could be possible. Just some graft to the meniscus and then pull down to the tip of the fibula. I did it with the sutures. I put the sutures from the superior anterolateral approach going down. I have the anterolateral approach and anterolateral but superior approach. Then you go down deeper and you can just catch here with the suture and put the suture down. That's what I do. And that's really nice, stabilize the meniscus. But I think the graft would be the better solution, but technically would probably be very good.
Roshan?
Yeah, yeah.
Roshan?
Yes, sir.
Can I ask him?
Yes, please.
Robert,
Yeah.
Robert, there are a lot of variations that are reported in the posterolateral corner of the knee. In your dissections, have you found these variations? Because I think Watanabe and all have shown some 7 or 8 variations in the posterolateral complex.
Yes, of course. There are many. Yeah, please continue.
And what is their significance? I mean, which are the most constantly seen variations, and what are their significance?
I would say that probably with the variation, generally with the anatomical variation, the problem is that every one of us is different, just a little bit different. That's what I try to show you on this anatomical dissections and this presentation, that we should look for this structure. And I just presented you the importance of the structure. But I cannot say 100% that, for example, if you cut the one structure in, for example, one patient will be the same effect like you cut the same structures the other patient. And the other thing, in the knee injury, we have sometimes very complex injury of different structures. And when they heal, I would say, sometimes all together. That just we get the big scar tissue which stabilize the meniscus, and we cannot differentiate each structure separately. Sometimes in the fresh cases, I just can put the suture on the popliteal fibers or the meniscofibular fiber ligament and so on. But of course, the variation there's very often. But the key of my presentation is to show which structures we should look for. And then we should take under consideration how we should repair that, because every structure is important for the perfect knee mechanic or function. I don't know if it's a good answer on your question.
Yeah, Dr. Robert. Hello.
Yeah.
Adding to Dr. Roshan's question, in your slide, you had shown the deep part of ITB. Now the deep part of ITB is going distally to get inserted between the Gerdy's tubercle and fibular head. So now this deep part of ITB is same as ALL, or distally diverges to be inserted at 2 points, or how we can differentiate distally?
It's different than the ALL.
ALL is different.
Yeah, different, but
yeah. Let me show this.
If you can show that slide, so things will be clear.
I'm just looking for that slide.
No, but Robert, is it easy to identify clinically?
What do you mean?
The two separate structures, are you able to identify clinically, especially when you have injury to the knee?
Yeah, in my hands, it's if you know what to look for, you can do. This is, for example, some dissection. If we look for the deep IT band, this is the deep. This is maybe the next slide will be here. Let me see. This is the movie. That's what you can see. What I cut now. This is superficial IT band. Yes. Deep IT band is here. LCL is here. It's not visible now. And then if we go with the next step. Can you see the structure here? This is deep IT band.
Yes.
ALL is the different structure which is running like here. There are two structures which are crossing or not crossing, they're under different angles. If you want to see the importance, look what happened when we cut the deep IT band. That's really increased the rotation.
Yes.
And I did the same cutting study with the ALL. And in ALL, the rotational instability is much smaller. There is nice research done by Andrew Emis and Christopher Kittel from Germany. And they did the cutting study and biomechanical study. They cut the deep IP band, ALL, and they did the reconstruction after that. And they just showed on the study that the ALL has very small importance for the rotational instability, but the bigger, the massive instability we can expect when we cut the deep IT band, which is in fact easier to reconstruct, because the deep IT band, there is the Lemaire procedure, is this is the reconstruction or the tenodesis of the deep IT band, Lemaire procedure. For the ALL, we have the segment fracture, and this is exactly the structure. We can make the reconstruction, like, for example, Bernard's hypothèse.
But Robert, one more thing. Many of these ligaments on the posterolateral side, the capsuloosseous fibers or capillary fibers, they may be attached to the bone on one side, but they are not attached to the bone on the other side. In other words, I feel many of these ligaments are basically dynamized by a lot of other structures in terms of whether it is the muscles or whether it is the position of your thigh, etc., etc. Unlike an ALL, which is a bone-to-bone structure, and many of the reconstructions that we are looking at we are doing it from bone to bone, which probably is more like a static stabilization, not a dynamic stabilization, which is very difficult to mimic. And that is precisely why these small fibers are able to contribute to a greater amount of stability than the other thicker fibers like the ALL, which is actually bone to bone.
Yeah, you're right. ALL is bone to bone, but the deep IT band is also bone to bone. Because I will show you again this. This is.
No, I'm talking about, say, the popliteal fibula. Yeah. That's not bone to bone.
Popliteal fibula.
Yeah. So that's not bone to bone. That is from the popliteal tendon to the bone.
Sorry. You skip to the very posterior part. Let me find it. Yeah, of course, you're right. This is the
Hello.
Popliteal fibula ligament. The fibula, can you see that?
Yep.
Yes.
One attachment is to the fibula, and the second is a part of the
popliteal tendon.
Popliteal tendon. And this is something what dynamized the movement control, because the popliteus muscle is very important for the all lateral side mobility and the movement. The popliteus muscle is locking and unlocking the knee, while the full extension and the starting to flexion, and also is pulling the meniscus backwards, is stabilizing the rotation. It's very important. There is also interesting about the popliteus tendon. That popliteus tendon, popliteus muscle, has two layers, has two parts. One is deeper, as I will say this the articular part, and the second one is the superficial part. And usually, when we have the popliteus tendon injury, in the incomplete rotational instability, there is the rupture of the superficial. There is not full rupture of the popliteus tendon. This is elongation around 1 centimeter of the popliteus tendon. But this is a separate topic. If you want, we can just talk about it. I have some dissection and some clinical cases for that. That the popliteus, I don't know if you can see me. Hello?
Yes.
Yes.
Popliteus has two layers like that. Yeah, and this is superficial, and this is superficial is here. It's more superficial. Deep is closer to the joint, and in the many cases, the superficial is ruptured and makes some flip, and then we have only the deep one, and that's enough, because then the popliteus tendon is elongated around 1 centimeter. Well, that's subclinical, I would say, the rotational instability, or the little clinical rotational instability.
Is there any question, or we should move on to the next talk by Robert?
Next.
Ranjit?
Yeah,
we should move on to the next talk.
Next talk. Dr. Robert, if you can share your screen.
Hello?
Hello, we can hear you.
Can you hear me?
Yeah,
yes,
we can hear you.
Okay, I will go now to the meniscus, and I think that we will have also some discussion after that.
Yes, we'll have more discussion on meniscus.
There is okay. Can you see the presentation?
Yes.
Yeah.
Yes.
And I'll just mute everyone.
The medial is hello?
Yeah, you can go ahead.
All right. I just published the paper about the medial meniscus anatomy, and this is, we propose to divide the medial meniscus on the different 5 zones. Zone 1 is the anterior root of the medial meniscus, and the zone 1 is very typical. There's the sharper fibers, and the histological construction, histological anatomy is like the more closer to the ligament than to the meniscus. Then we have the zone 2, and in the zone 2, as you can see on the right-hand side, we propose to differentiate zone 2 into 2 parts: zone A, 2A, and 2B. 2A is from the anterior root to the intrameniscal ligament, which is supposed to be in more than 80% cases. And then the zone B is from intrameniscal ligament to the anterior border of the medial collateral ligament. Well, and the zone 2A, has typical histology for the ligament, as well as the closer to the anterior root. When we go to zone 2B, in the zone 2B, meniscus has typical histology for the meniscus with the internal architecture. But very important thing, in this area, meniscus is attached to the tibia via the coronal ligament or meniscofibula ligament, and there is no meniscofemoral ligament, but there are some how to say, some parts of the or some reinforced synovium, which looks very similar to ALL or MPFL, but it's very strong and attached to the meniscus and attached to the femur. Sometimes we can talk about the meniscofemoral ligament I will show later on, but also the deep MCL, some fibers of deep MCL. There is no direct attachment to the femur in this zone A2B. Then we go to the very interesting zone. There is zone 3. Zone 3 is next to MCL. Why is interesting? Because in zone 3 there is only characteristic that you have the MCL, which is here, and then we have these two parts, meniscofemoral and meniscotibial, or coronal ligament, and meniscofemoral ligament. In between, in this area, we have I will show you, in this area, we have vessels, very small one, which are responsible for the nutrition of the meniscus. That's why this vessel are going like this to the meniscus. Right. Zone 4 is very secret zone, I would say, or a very undiscovered zone. Because in zone 4, the zone 4 is the most hypovascular area on the medial meniscus. It's attached only to the tibia. That's what you can see here. This is the synovial membrane. This is the capsule with the white arrow and the red arrow, and the black arrows. There is the lower border attachment area to the femur, to the tibia. And what is also very important, this is the also area where you can get the ramp lesion. This is very interesting part of the medial meniscus. If you look to the medial meniscus through this gap, you can see again that the superior border of the medial meniscus is completely free, but the inferior border, or the inferior part, is attached to the tibia. And this is the example. This is the zone 4. You can see the superior border, which is free, and the inferior part of the meniscus is attaching to the tibia. And this is the coronal ligament. And the blood supply to this part of the meniscus is going through this small meniscofibula, the tibial ligament. That's why this part is very hypovascular. That's why when we look at this area, zone 4, there's the most degenerated part of the medial meniscus, in my opinion, because of the very bad vascularization. Zone 5, finally, there is the posterior root of the medial meniscus, and for everyone who is doing the meniscus transplantation, zone 5 is under the PCL. It means it's very hard to get it, and of course it's very hypovascular. It's a very bad vascularized area, and if we have the posterior medial meniscus posterior root tear, then this any kind of suturing, in my opinion, is useless. There is the paper. There was the paper published in this year from Chinese group that there is no difference. Of course, according to the osteotomy, there is no difference. There is no benefit of suturing the posterior root of the medial meniscus and osteotomy, or only the osteotomy. In my hands, when I have the posterior root tear, I do anything, or I do just the small osteotomy of the open wedge osteotomy. What about the lateral meniscus? We start to discuss it, but this is also very interesting. I propose to differentiate, or to have the 5-6 zone in compared to the medial meniscus is the 5, lateral is 6. Zone 1 is anterior root of the lateral meniscus, and now we go back to the anatomy of the ACL, because the anterior root of the lateral meniscus is back to the posterior to the ACL attachment. And you can see here why it occurs like this. Then we have here the anterior root of the lateral meniscus, and the ACL is in front of it. These are small tunnels for the vessels and nerves. Zone 2. Zone 2, or the mobile zone, is very important. Here you can find a very thin layer, looks like a very thin synovial layer. And this layer of the synovium is making kind of recesses on the medial side, on the lateral side. But this is very important. This part had to be very thin and very mobile and should allow the meniscus to move posteriorly and anteriorly. If we put the two strong sutures, two rigid sutures in this anterior part, then we fix the lateral meniscus closer to the extension, and then is the problem with deflection that we can just damage the anterior suturing, or we can just limit the deflection. And this is the attachment of the very thin synovial layer, as you can see here with the black arrows. And on the third picture, I removed that, and then you can see in the small flexion, slight flexion, how far posteriorly moves the meniscus. Then we have finally the zone 3. I just showed a little bit about the zone 3. There is the popliteal tendon, there is the popliteal meniscal fascicles, and meniscofibular ligament. And this is the meniscofibular ligament, and in zone 3 as well. You can see the same picture I showed you before. Right, and this is also the same, and this is the arthroscopic view. I put my scope from the anterolateral superior portal, and the scope is here. This is the popliteal tendon, this is the lateral condyle, this is the meniscofibular ligament. Zone 4 is just coronal ligament, meniscus, and the tibia. This is the meniscotibial ligament. There is a pretty long structure because allow the meniscus moves anteriorly and allow the meniscus moves posteriorly. This is the coronal ligament from different angles. Then we go to the zone 5. And opposite to the medial meniscus, zone 5, I call it the ligamentous zone, because in this area we have the 1, 2, 3 ligaments, the Risberg, Humphrey, and meniscotibial ligament. This is not the root, this is the meniscotibial ligament. And when you look at the picture, the meniscotibial ligament is creating the circle with the ACL sometimes. Again, we have the Humphrey, meniscofemoral anterior, meniscofemoral posterior Risberg, and meniscotibial ligament, which is in the continuation with the ACL. This is zone 6. Zone 6 is the area of the posterior root. This is not the posterior root, this is the meniscotibial ligament. Especially here, I would like to show you because it's above the posterior root of the lateral meniscus, and the lateral meniscus posterior root is under the meniscotibial ligament. This is very important for the meniscus stability. What about the blood supply? You can see the knee from the posterior. You can see here, this is the lateral inferior genicular artery, medial inferior genicular artery, and this small one, this is the lateral superior genicular artery. Medial is a little bit higher. And this small one, this is the only blood supply, only vascularization which is going to the medial meniscus. And this is the medial meniscus artery. When we go deeper, you can see here, this is the medial meniscus artery. This branch vascularized posterior root and the zone 4. Just look at it and look how thin and how small is the blood supply to the medial meniscus, especially from the posterior border of the MCL to the posterior root of the medial meniscus. If you compare this artery to that one, this is going to the lateral meniscus, this is going to the medial meniscus. That could be kind of explanation why the medial meniscus, especially zone 4 and zone 5, is so often degenerated comparing to the lateral meniscus. And if you can see this structure, this is the small nerve which is running together with the artery. From the lateral side, you have here the middle genicular artery, which is going through the gap in the posterior capsule to the PCL and to the partially to the ACL, the superior lateral genicular artery, inferior genicular lateral artery, medial inferior genicular artery, and the medial meniscus artery, and the medial superior genicular artery is a little higher. In summary, if we talk about the medial meniscus, I would just suggest that the medial meniscus should be fixed to the bone if we have the injury of this anterior or posterior root, or zone 1 or zone 5. However, in zone 5, posterior root, the intraosseous fixation can help sometimes, but the potential, the healing potential in zone 5 is very, very low. In zone 2, I use the outside in suture, and usually I fix the meniscus down to the tibia, because the most important fixation of the meniscus is the meniscotibial fixation. In zone 3, as you remember, the zone 3 is the next to the MCL. I put the up and down sutures as here, because in between the sutures red and yellow there are the vessels. They should supposed to be vessels. Zone 4 has no connection to the femur, is only connected to the tibia. That's why if I have to suture it, I put only down the sutures under the meniscus going down. Or if we have the ramp lesion, of course the ramp lesion is kind of the zone 4 injury, meniscus injury, then I put the circular suture resorbable. In summary, in the meniscus, in the lateral meniscus, we know from the clinic, if we have in the biomechanic, if we have the root in injury, we should fix it to the bone, because for the meniscus, the bone fixation is maybe very important, is one of the most important things, because close the circle and then meniscus can play the role as the buffer. And there is now an interesting question. If we do the classical single bundle ACL reconstruction, very often we damage and we destroy and partially at least the anterior root of the lateral meniscus. Posterior root of the lateral meniscus is very important for the meniscus stability. There is many biomechanical works, papers about it. This is very important structure. That's why it should be fixed to the bone. Then we had zone 2 to A to B. Honestly, I don't suture this part of the meniscus. If you have, this is not important for the meniscus stability at least. I never heard about the subluxation or the bucket handle of the anterior part of the lateral meniscus. But if you put too strong suture in the front, then you make this whole construction too rigid. Have to be more flexible. That's why I don't put any suture here, or if you like, it should be a fast resorbable suture like the Vical Rapid. Zone 3 is interesting. As I said in the previous talk, that should be menisco-popliteal fascicle should be sutured. Menisco-fibular ligament should be also managed. Zone 4 is easy. I put the all inside down suture in the zone 4 for the meniscus. Sometimes if I can put my scope to the back, I make the circular sutures very similar to the ramp lesion. Zone 5, honestly, what is the exactly biomechanical role of these ligaments, the meniscofemoral ligaments, the meniscotibial ligaments? They are fixing the meniscus and tightening the meniscus depending on the flexion and extension. And in some cases, I use the Humphrey ligament to replace the lack of the posterior root to destabilize the meniscus, but I don't know exactly what to do with these ligaments. That's it. Thank you.
Thank you, Robert. I think that is a wonderful description of meniscus anatomy and zonal system, which we were never aware of, because whenever we repair it as the body, the anterior root, posterior root, and that's a simple description of meniscus. But we never aware of such kind of zonal system does exist. So anybody has a question on meniscus, lateral and medial?
Roshan.
Yes, Dr. Antao, yes, I can hear you.
Yeah. Thank you, Dr. Robert, for a lovely, wonderful disposition of the meniscus, which we have never heard before. Between the blood supply of the lateral and medial meniscus, lateral supposed to be having more blood supply compared to the medial side. And at medial one takes more weight and more load. Why is it like that?
I don't know. We have to ask the God why it's like that. But that's true. The lateral meniscus is, I think the lateral meniscus is very important for stability and has really big arteries. They just give the blood supply to the lateral meniscus. I call the lateral meniscus ML, means LM, lucky meniscus, and the medial meniscus, miserable meniscus. Because the medial meniscus is really very badly vascularized. Lateral meniscus is good vascularized. If you put the suture on the lateral meniscus, it's supposed to heal better than on the medial meniscus. That's my opinion. Why is that? I don't know. I'm working on it. Maybe I can tell you in 1 year.
So Robert,
in zone one of lateral meniscus, invariably when you see arthroscopy, there are always interstitial tears in the zone 1 of lateral meniscus. And very often you see this also when you do a total knee arthroscopy. Now, how often the ACL is engulfed by this zone 1 and the intermeniscal ligament?
You mean zone 1 is here? Yeah?
Yeah.
Yeah, this is the intermeniscal ligament. It's in more than 80% of my patients. That's if I cannot find the intrameniscal ligament, probably because I just damaged it, not because that doesn't exist. This is the zone 1, but what I would just I would be scared about the damaging of the zone 1 when we put the tunnel for the ACL, because then we have to damage the ACL, some fibers of the zone 1. If it's biomechanically important, I don't know, but maybe. But I didn't see any biomechanical study about the. However, no, I have some, but there is not so maybe significant, very significant influence of the meniscus stability. I don't know what. There are many fibers here. I don't know what if it's okay for you.
Can I ask? I have 2 questions.
Yeah, Nishith sir.
Yeah. One, Robert, what is the function of the ligament of Brisberg and Humphrey? And second thing, that if I have an anterior horn lateral meniscus tear, which is avulsed and which is giving symptoms, if I do only soft tissue repair, will it not work?
They shouldn't. I would like to answer it as the second question. For the meniscus function, it's very important to be fixed to the bone, because then meniscus is just, that's important for the meniscus function. That was also the big discussion about the meniscus transplantation. If we do the meniscus transplantation, should we fix it to the bone or can we just suture to the capsule? That was the discussion a couple of years ago. But actually, we know that for the meniscus function, to restore the real or proper meniscus function, the meniscus have to be fixed to the bone. That's the first.
So bone block meniscus transplantation will be better than the no block transplantation, right?
Yeah. Okay. And the first question what is the role of the meniscofemoral ligament? Honestly, I don't know exactly, but they just the 2 or 3 ligaments, they control the movement of the meniscus and they tie the meniscus according to, depending on the flexion or extension, the different flexion or extension angles. When I observe
how much is the contribution, means how much it gives stability to the meniscus in flexion and extension?
I don't know.
Okay.
I don't know. I don't know the answer on the question. But when I observe the knee in the movement,
right,
there is the how to say the dance between the meniscofemoral ligaments and the meniscotibial ligament is interesting because they sequentially they tight or be loose. You know, that's you know what I mean, yeah. And that's they play any role, but how important are these ligaments biomechanically? I don't know.
Okay.
Okay. Any other question to Dr. Robert?
Yeah, to add to that question of Nishith sir, in discoid lateral meniscus tear, can we leave without repairing the posterior root of lateral meniscus if your ligament of Humphrey and Risberg are totally intact, or we need to repair it?
No, I think what Robert has shown, we have to repair it, you know, because we do not know how much it is contributing to the stability of the posterior and of the lateral meniscus. So it will be better to do a osseous repair, as he has said. Robert, what do you say?
Yeah, you know, the lateral meniscus, the discoid meniscus is an absolutely different story because the discoid meniscus has very often no posterior root. There's like a disc which is lying between the femur and tibia, but has some ligaments which fix the meniscus.
So you have to repair, right? You should repair the lateral root in discoid meniscus, right?
The discoid meniscus, the posterior root, I wouldn't do anything now with the meniscus. And now I even just I'll just reset this the damaged part of the meniscus and just leave the meniscus like that because there's no normal meniscus. It's not abnormal meniscus. There's absolutely different anatomy. If we just resect too much, then the meniscus will be unstable. At least we should fix it to the posterior part of the zone in the anatomy.
Many times we do not see anything in the posterior horn of the lateral meniscus in the discoid, you know. Usually it is the medial part which is more affected, you know, the tear is in that part. So I understand.
Yeah, Dr. Robert, you said you don't believe in suturing the posterior horn of the root of the medial meniscus.
Yeah.
And now in the when there is a sort of a lumpish tissue, when the end gets swollen up and it impedes and causes pain. So how does one get rid of this pain?
You mean the pain on the medial side?
Medial or lateral side. The end, when it gets swollen up, it becomes a little bulbous.
Yeah, but if we talk about you started to ask me about the posterior root of the medial meniscus, yeah? Yes. And the posterior root, if you have the rupture of the posterior root of the medial meniscus, honestly, I did couple of times some suture there. And during my arthroscopy, it was perfect, but it doesn't heal. It didn't heal. That was the problem. Because there was a good intraoperative effect, but no clinical effect afterwards. And the patient, they has progressive arthrosis on the medial side with the pain. In the cases when I have the posterior root tear, I go for high tibial osteotomy, even 5 degrees, sometimes 3-5 degrees, small one, but just try to remove just a little bit the load forces on the medial side and the meniscus then, the function of the meniscus is better.
So you think it's only the osteotomy that will relieve of the pain? What about the mechanical symptoms?
Yeah, but you know, to the relief of the pain, there's the bigger discussion. There should be the bigger discussion why the meniscus is torn. If it's the post-traumatic injury, there is in the young people, the potential for the healing is maybe bigger, and there's no leg alignment disturbance. Maybe we can just think about something to some refixation. But if we have the older patient with the leg alignment, which is more varus knee and more degenerative changes, I would go for the osteotomy. Even small one, even not so big one, even small one.
What do you mean by small one?
The small one is like between 3 to 5 degrees.
Okay, and how do you fix it? Same?
Same. I use the Tomofix.
There is a paper which is shared by Alessandra. In fact, I have posted on our group. She had the concurrent arthroscopic meniscus repair during the open wedge high tibial osteotomy is not clinically beneficial to the medial meniscus posterior root repairs. Can you elaborate more on this, Robert? This is from China, I suppose.
I know this Chinese paper. That's exactly what they write, that in the posterior root injury on the medial meniscus, if we decide to make the osteotomy, we don't have to put the suture on the posterior root, because it don't change anything. This doesn't matter if you put the suture on the posterior root or not, you will have the same effect. The osteotomy just solved the problem.
Okay. Any other questions?
Yeah, Roshan, can I ask?
Yes, please, JP.
Yeah, Robert.
Yeah.
Hello, Robert.
Yeah.
So, according to your presentation on the in the medial meniscus, zone 2, zone 4, and the lateral meniscus, zone 2A, zone 2B, and zone 5. These are more mobile. Okay. So, in clinically, what we are doing, we are fixing inside out or outside, all in. Is it a correct method? Like, we are making it very stiff. It is anatomically, what you are saying is the extension of the capsule will be there. There is a movement in these zones. So when we are fixing very tight at these zones. So from zone A, zone AB, and zone 2A and 2B, and on the lateral side, and zone 5 on the lateral side, and zone 4 in the medial side, and zone 2 on the medial side. So, and I mean, what is your opinion? Like, we are fixing very tight with this all inside or outside in? Do you advise modify our method of our fixation, like some capsular suturing or something like that, or it should not be very tight? What is your opinion?
No, that's what I said before, that if we have some tear in the very mobile part of the meniscus, I would do nothing. Or I would just put the fast resorbable suture, just to put the meniscus together, this damaged part, and just leave them to heal. Because, especially the lateral meniscus, the only part of the lateral meniscus which is very bad vascularized is the zone 3, under the popliteal tendon. There is not good access of the blood vessels to the meniscus. The rest of the lateral meniscus is very well vascularized. I have a different talk, different presentation about the meniscus blood supply, medial and lateral. Just I have a special talk about it. But honestly, in all the mobile parts, the very movable part of the meniscus, we should really very much think about how to fix it. I wouldn't do anything, or I would just put a very fast resorbable suture, just to adapt the tissues, not to fix the tissues. Otherwise, we can damage the biomechanic.
Okay. Any other question before we wrap up?
Roshan.
Yes, Dr. Antao.
Dr. Robert, when you suture the medial meniscus and the lateral meniscus, in medial meniscus, when you release the tourniquet, there's much more flushing of the blood that comes, as compared to that on the lateral side. Any reason for that?
I didn't observe it. The medial side is definitely much worse vascularized than the lateral side. I didn't observe it. I cannot comment. That's why.
Yeah. Roshan, can I ask one more question?
Yeah, please.
Yeah. So, Robert, this intermeniscal ligament, if this get damaged, do you recommend to reconstruct this intermeniscal ligament?
Good question. I did some study about the intermeniscal ligament, and the intermeniscal ligament control the position of the meniscus during the rotations. Because when I have this separate videos, how looks the behavior of the medial and the lateral meniscus. If it should be reconstructed, probably yes, but we don't know how to tie this ligament, how to put the initial position. Because we can put the structure there, but sometimes if we put it too tight, then we'll just make some small subluxation of the meniscus. But
how do you repair it?
Pardon?
How will you repair it?
I don't repair that. The intermeniscal ligament, I don't repair the intermeniscal ligament.
You should not even cut it, right? Because there are people, they remove it especially when they do avulsion surgery.
No, honestly, if you have something in the front of the knee, close to the Hoffa-Fettpad is perfectly vascularized, and the bleeding is mostly from the Hoffa-Fettpad. Even if you don't put any suture there, you will get the big scar tissue in the front of the knee. If you make some second look arthroscopy, the most scarified, the most part of the knee with the scar tissues is the anterior part of the knee, under the Hoffa-Fettpad. I don't fix the meniscus in the front. There is not necessary.
Robert, the question was very wide. Then what is the function of intermeniscus ligament?
The function is just to control the position of the meniscus, first of all, during the internal and external rotation. Because if you want, I would say another thing. If you want, you can just write the question or topic you are interested mostly. I will just prepare for you, if I have some materials, some short talks about it. If you want to know something about the structures I didn't talk about, just send me the question.
Yeah. I think you covered a lot, because I think what we learned today, all of us will agree. I think it was added to our knowledge, because many of the things we are not aware, especially the popliteofibular ligaments and popliteal meniscus ligament. I was completely not aware. The zonal system of meniscus was completely new to us.
And repair according to the zones,
Yeah. So the repair strategy per zone, that was also not new, not known to us, and it's a very new thing to discuss about. If there are no questions, I'd like to thank Dr. Robert for giving his time. Wonderful 2 hours we spent on learning anatomy of knee, posterolateral corner, and the medial meniscus and lateral meniscus. Next time, Robert has promised us to speak about the hamstring biomechanics, and I will request him here to add the patellofemoral instability if he can, because that is one thing which I'd like to know in great detail as far as the patellofemoral instability is concerned. If you agree, Robert.
Yeah, of course.
Yeah.
With pleasure.
Thank you. Yes. Thank you, everybody.
Thank you, everyone.
Thank you.
I'll just make it off live now.
Once again, thank you to you, dear.